This is the human side of healthcare, where we explore all aspects of today's ever-changing healthcare environment. Brought to you by the Dallas-Fort Worth Hospital Council and featuring CEO Stephen Love with co-host Thomas Miller. Now, let's make healthcare human again.
And welcome to the human side of healthcare. We're delighted you're with us today. And today we want to talk about a very important topic. It deals with prostate cancer, also PSA screening. We couldn't have a better expert than Dr. Yair Lotan. He's the medical director at the Urology Clinic, Parkland Health and Hospital System. He's also a professor of urology, and he's the chief of urologic oncology at UT Southwestern Medical Center. Dr. Lotan, welcome to the show.
Thank you very much. I'm pleased to speak with you.
You know, I know that prostate cancer is something that we hear a lot about, but for our listeners out there, both men and women, can you define prostate cancer?
Sure. We get cancers in a variety of different organs in the body, and the prostate happens to be an organ that sits right below the bladder, and the urethra runs through it. So when men urinate, the urine exits the bladder, goes through the prostate, and then out the urethra. The prostate's main goal is to create secretions that help with semen survival and longevity. And so mostly it's an organ that's useful for fertility. Unfortunately, it is also an organ that can commonly develop cancer, especially at older ages. And in fact, prostate cancer is the most common cancer in men and the second leading cause of death among men among cancers. And so it is unfortunately a common condition that impacts men, especially as they get older.
You know, you mentioned it's a common condition, especially as you get older. Are there different forms or types of prostate cancer?
Well, the prostate is a gland that makes secretions. So almost all the cancers fall into a category called adenocarcinoma, which is the type of cancer that you develop in glands, similar to breast cancer, for example, in women. As far as the different types of cancer, almost all are adenocarcinoma. However, they come in different types of aggressiveness. So a lot of prostate cancers are relatively benign or indolent, which means that they rarely grow fast and they don't usually spread. However, about 10 to 15% of them can be quite aggressive. So just because you have an adenocarcinoma of the prostate, some men will have an aggressive form, some will have a less aggressive form. And so it's hard to categorize it as just one cancer, in the sense that just telling somebody you have prostate cancer does not tell you very much about their prognosis, how it'll behave.
You know, for some men that may catch their prostate cancer late, by that I mean later in the progression of it, does prostate cancer usually then spread? And if it does spread, where does it normally spread?
So I think just your terminology, when you find it late, that usually implies a late stage. So early stages usually are confined to the prostate. Late stages often will have spread either to the lymph nodes or outside the prostate to other organs. The most common place that prostate cancer spreads is actually to the bone, but it can spread to the lung, liver, as mentioned, to the lymph nodes, and it can also cause problems by growing locally and blocking organs such as the kidney.
You know, when you talk in terms of prostate cancer, especially to the men out there, what would you say are some of the key risk factors related to prostate cancer?
Sure. Unfortunately, most of the risk factors are ones that we cannot control. A family history is a significant risk factor, and it's an important thing to discuss within the family. Did your grandfather have prostate cancer? Did your father, uncles? Because a first-degree relative who has prostate cancer will double your risk of having prostate cancer. And so it's actually important to have a discussion. It's not always a comfortable topic for families to talk about cancer, but it is an important history and can help you determine, when you should get screened and how often you should get screened. The second factor is that African American men and men from the Caribbean with African ancestry are also at a significantly higher risk than Caucasian or white men. And so that's another factor we don't control, but it does have an impact on timing of screening. The factors that we do control contribute some, but not quite as much as family history or race, and that is smoking and obesity. They both have been shown to have an impact on the risk of prostate cancer.
Are there any signs or symptoms that men can experience that would give them an indication that they probably need to see a medical professional?
So I would start off with the fact that we don't want to wait until we have symptoms from cancer. That almost always implies that the cancer is more advanced and has been there for some time, or has gone to a separate organ where it does not belong. And so symptoms tend to be relatively late, and some of the symptoms that we do attribute to prostate cancer are relatively nonspecific because they can be attributed to men with enlarged prostate. The vast majority of men we diagnose because of an elevated PSA with no symptoms whatsoever. So having no symptoms is not a reassurance you do not have prostate cancer. The symptoms that you can experience are local symptoms, those sometimes irritation to the urinary tract, some frequency or urgency, but more common than not, that is related to an enlarged prostate, not prostate cancer. Very late, you can have bone pain if the cancer had spread to the bones. You can have flank pain or pain in the kidneys if the cancer is blocking your kidneys. And you can have a variety of other symptoms if the cancer has gone to a different organ. But as I mentioned, that's really not when we want to find cancer. That's usually a fairly late symptom.
You know, you mentioned a PSA test in your response. So can you talk about what is a PSA test, and is it a good screening test for prostate cancer?
Sure. So the PSA test stands for prostate-specific antigen. And note that I did not say prostate cancer-specific antigen, but prostate-specific antigen. It is an enzyme made by the prostate, and it is made both by cancer cells and by normal cells. It can be detected with a simple blood test. And in most men, this blood test shows a low level of PSA. But because prostate cancer attracts blood vessels so that it can grow, more of the PSA can spill into the bloodstream. And so men with prostate cancer have an elevation of this test relative to normal men. Unfortunately, other conditions such as enlarged prostate or inflammation or infection in the prostate can also cause the PSA to go up. So it is the best test we have, but it's not a perfect test, which means that many men who undergo a biopsy to detect cancer because of an elevated PSA do not have prostate cancer. On the other hand, as I mentioned earlier, it's the best way to find cancer early, which is the best chance of curing a man of cancer. So it is important for us to get evaluation of the PSA, ideally yearly, along with an exam, in order to find prostate cancer early.
And just to bring those statistics home, the American Cancer Society estimates that there are 250,000 new cases of prostate cancer each year in America. It causes nearly 35,000 deaths per year, and 1 in 8 men will be diagnosed with it during their lifetime. We're talking to Dr. Yair Lotan. He's medical director of urology at Parkland Health and Hospital System. And when we come back, we're going to ask him the very important question: when should you start getting tested? That's next on the Human Side of Healthcare.
This is the Human Side of Healthcare, where we feature healthcare's hottest topics and what our North Texas area hospitals are doing to make healthcare human again.
Welcome back to the Human Side of Healthcare. We're continuing our conversation with Dr. Yair Lotan. He's the medical director of urology at Parkland Health and Hospital System, also a professor of urology at UT Southwestern Medical Center, talking about this 1 in 8 chance that men could get prostate cancer in their lifetime and what to do about it. And the beginning of that process is indeed getting tested. Steve?
To our men that are out there listening, you mentioned it's important to get tested regularly. At what age should men start PSA testing?
Sure. And this goes back a little bit to your risk factor question. We try to determine the age of screening based on your risk. So, for example, if you are a typical man with no family history who is white or Caucasian, then age 50 is a good age to start with an annual exam. African American men, because of the increased risk, should really start at age 45. And if you're a man with a very strong family history, probably need to start at age 40. And this, when you start, we think people should get a yearly test, and you are really your best advocate. Some physicians don't necessarily order it at that age. You need to tell your doctor, I'm at a higher risk. My dad had prostate cancer, or my brother, or my uncle, and can you start screening me every year? And I often tell men, you should record your number just like you might know your cholesterol. You should know your PSA level. And if it starts rising more rapidly than one would expect, if it goes up by 20, 30% a year, then you need to be concerned and ask to see a urologist.
Let's follow this along. Let's assume you go in routinely, your PSA elevates, and you go to the urologist, and as you indicated in your answer previously, it's determined you need a biopsy. And a biopsy is performed, and you get the results back. I think those are charted as Gleason scores. Can you walk our listeners through, I don't want to get into too much detail, but the importance of Gleason scores?
Sure. And we're actually going through a transition in urology. The Gleason score is named after a pathologist named Dr. Gleason, not surprisingly, who developed a scoring system from 2 to 10, which really gives the relative aggressiveness of the cancer. Now, interestingly, over the years, it was decided that grades 2 through 5 are not cancer, so 6 is really the lowest you can get, 10 being the highest. And typically, we consider 6 a low risk, and then 7s are intermediate risk, and then 8 through 10 are high risk. And so they're actually transitioning to a system from 1 to 5, which is more recognizable, 1 being what used to be a 6, Gleason 6, and 5 being what used to be Gleason 9 or 10. And this actually is a new grading criteria. But this grading criteria is quite important because we actually often will recommend active surveillance and not treatment for the classic Gleason 6 or the new grade group 1, because most of those men will be very unlikely to die of prostate cancer if monitored carefully. And then treatment is really geared towards men with a more aggressive disease. And so categorizing the cancer, which is based on your exam, your PSA, and your Gleason score, really affects what kind of treatment recommendations you might have, or even if you need treatment at all.
That's a great answer, and I know it's a lot of detail, but I'm trying to really help, especially the men out there, understand this. So now you've gotten your Gleason score back. You've consulted with your urologist. It's determined you need treatment. What are some of the treatment options for prostate cancer?
The good news is that for early prostate cancer, there is a very high cure rate with either surgery to remove the prostate or radiation to give radiation to the prostate itself. These are standard treatments, and there are a variety of different ways of giving radiation. It can be given through sort of standard hyperfractionated ways, which is usually over a couple of months. There are also some stereotactic ways to give it over a couple of weeks. There are also some newer therapies, and in some men with very localized prostate cancer, there's some efforts to consider focal therapies, but those are still mostly experimental and really should be done sort of on a very selective basis.
Is the most common surgery performed for prostate cancer robotically?
Yes, over 99% of all prostates in the U.S. are removed robotically, and there's some exceptions in cases who've had a lot of pelvic surgery, but in those patients, when I'm worried that there might be a lot of risk of complications, then I often will just recommend the men have radiation, which is an excellent option also for treatment to avoid some of the risks that might occur if they've had a lot of pelvic surgery. But yes, the robotic surgery usually takes 2.5 to 3 hours, usually one night in the hospital, and relatively low risk of complications.
Full disclosure to our listeners, unfortunately, I was diagnosed with prostate cancer, caught it early. I did my PSA screenings. But I want men to understand the importance of PSA, not only from a diagnostic point of view, but as you would know, I go back for my routine cancer checkups post-surgery, but they still check my PSA. Why is it important to check PSA even after your surgery or radiation?
I think we can take a step back. PSA was actually developed as a surveillance tool. Surveillance tools are used after treatment to try to detect whether or not cancer comes back. And as I noted to you, it's really made primarily by the prostate. And so if you remove the prostate, you really should have little to no PSA in your body because nothing else makes it. And so it's an excellent tool for following men after surgery, because if you remove the prostate, PSA should be undetectable. And if the PSA ever starts rising, it tells you there's prostate tissue somewhere in your body that's growing. Since you have no prostate, then it's your cancer that's come back. It was later used to try to see if we could screen for prostate cancer when it became a little bit more challenging, because you had to determine if the PSA was from your normal prostate or from a cancer. But as a surveillance tool to follow up men on treatment, it's an excellent tool because there are less confounding factors.
You know, you mentioned family history. You also mentioned obesity. You mentioned smoking. Are there other things that men can do potentially to help reduce the risk of prostate cancer?
No, really, generally speaking, this is one of those diseases that age and genetics really have a big factor on, and there really aren't too many preventative things. I tell people to do, to have a heart-healthy diet. I know a lot of people go to the store or GNC, Whole Foods, and there's shelves and shelves of different vitamins and nutrients and things like that. These are unproven. I hate for patients to waste money. If they have a heart-healthy diet, they're getting a good complementary, a number of vitamins and minerals. If they wanted to take some generic multivitamin because they feel like it's going to help their health, great. But I think that a lot of the things that are out there right now are quite unproven. Supplements, for example, are not regulated by the FDA. There's little to no evidence to suggest they actually improve survival, much less reduce the risk for prostate cancer.
I've thrown a lot of questions at you, so I want to give you an opportunity. To our men that are listening out there, is there anything about PSA screening, prostate cancer, or prostate treatment that I haven't covered that you'd like to share with our listeners?
I think the most important thing to me is that patients need to be their own advocates. There have been some mixed messages in the press, and I appreciate that you are talking to me at all. But the U.S. Preventive Task Force, for example, has changed messaging about PSA and given different grades to the test. And it's true, the test is not perfect, and we wish we had a better tool to screen for prostate cancer. And there are many primary care physicians that have decided that PSA test is not a good test and do not routinely do it for men. And men don't always even know that they're getting the test or not getting the test with their annual blood work, and their primary care physician may say your blood work's fine, but they don't know what was tested. They don't know if their liver function was tested or their kidney function or their cholesterol, and they may not know if a PSA test was done. And so I strongly encourage men to be their own advocates. Whether or not the test is good or not, that's a bit subjective, and that has a lot to do with how epidemiologists look at testing. But it is the best test we have. It is the number one cancer in men. It is the second leading cause of cancer in men. And we do have a tool that can help reduce the chance of dying of prostate cancer. And so I strongly recommend that men speak with their primary care physicians, at least ask them, do you get the test routinely? Why don't you think the test is good if they don't recommend it? And certainly you have to understand that urologists all recommend this test, and so does the American Cancer Society. And so I think patients, when they get to that age and they need to understand the risk factors, and they need to talk to their primary care physician and ask, can I have this test? And if not, what is the rationale for that?
Great information. Dr. Yair Lotan, Medical Director of Urology at Parkland Health and Hospital System, thank you for addressing PSA for us guys. When we come back, we're going to talk about cataracts, another thing that affects us as we age. Dr. Karen Saland from Texas Health Presbyterian Hospital next on the Human Side of Healthcare.
Welcome back to the Human Side of Healthcare. where we explore how to take better care of your health so you can live a happier, healthier life. With DFW Hospital Council CEO Stephen Love, along with Thomas Miller.
And welcome to the Human Side of Healthcare. We're delighted you're with us today. And today we want to spend a few minutes talking about cataracts. Yes, to our listeners out there, you may have experienced cataracts. You may have friends, family members, but we thought we would definitely go to an expert. And we're so delighted that we've got with us Dr. Karen Saland, who is obviously MD, but she's an ophthalmologist at Texas Health Presbyterian Hospital in Dallas. Dr. Saland, welcome to the show.
Thank you so much. It's great to be with you.
You know, for our listeners, what are cataracts and how do they affect one's eyes?
A cataract is actually a change in the lens of the eye. The lens sits actually inside the eye, behind the iris, which is what gives the eye its color. When we start out life, usually our lens is clear. With time, the lens can change and become cloudy. That cloudiness is what we call a cataract. Cataracts can affect your vision in a number of different ways. Primarily, it causes people to have blurry vision. Some people can also have double vision. It also can cause people to have light sensitivity, which really becomes an issue with night driving. And it can also cause some fading of colors.
Are there any uncommon characteristics associated with cataract development or symptoms?
Well, actually, one of the ones that I named is double vision, and I would say that's a lesser common association with cataracts. A lot of times when people are coming in with double vision, we automatically think about neurological causes and even more emergent things that we have to consider, but always keeping in mind that it could be a cataract that's causing the double vision, which is more of a fixable entity than something neurologic. So the double vision would be probably the lesser common symptom that a patient would have.
So when should an individual who's sensing some of these symptoms seek medical treatment?
I would say as soon as possible. It's not that a cataract is an emergent issue. We rarely will do cataract surgery emergently or even urgently. So it's not that you should seek the medical care because of the cataracts being urgent, but especially when cataracts are interfering with one's ability to do things such as drive, then one should seek the care of an ophthalmologist as soon as possible, because there is a likely chance that it's not even the cataract. It could be something else going on causing the blurry vision, such as even that your glasses need to be updated. So it's really important, primarily when one has any type of vision issue, to just figure out what is actually even going on. Sometimes it's the cataract, but sometimes it's things that we can actually modify or treat. So I would say that just sort of having a regular visit with one's ophthalmologist will reduce the surprise factor and also just allow you to have somebody to call when something unexpected happens, like a sudden loss of vision or even a gradual loss of vision.
You know, when a patient comes to you and you determine they have cataracts, are there stages of growth? For example, do you have some patients where they're just beginning cataracts and they can postpone surgery? Absolutely.
So we say that about the age of 40 is when we start to see this cloudiness of the lens. And the cloudiness of the lens that means that a cataract is starting to form. And the confusion about even using the word cataract is when people hear cataract, they automatically think, I need to have surgery. But in fact, that cloudiness starts at an age way before cataract is even symptomatic. So there are stages. We even rate the growth of the cataract on a scale of 1 to 4, or 1 plus is how we describe it, is the stage of an early cataract that usually doesn't interfere with vision and probably is not affecting anyone's life at all. Only when that person is examined under the slit lamp, which is what we call our microscope that we use to look at the eye, can we see those lens changes or cloudiness of the lens. and that's what we would call an early cataract. And at that point, we simply tell the patient that they have the beginnings of some changes that are not interfering with their vision, likely, but they can expect to see something in the future. And I like to just give patients a warning of what may happen in the future, even if it's something that's going to happen 20, 30, 40 years from that point. At least they'll know when it happens, this is what they can expect to see in the future.
You know, if you tell a patient that they're in the early stages of cataract development, is there anything they can do to slow the development of the cataract?
Yes, actually, there are a couple of things that a patient can do. A lot of cataract formation is just simply aging, but there are some things that we can do, such as if a patient is a smoker, they should be told that smoking is bad for the eyes. Smoking does increase the rate of cataract formation, so we would recommend that they stop smoking. It is good to wear sunglasses and use UV protection. That also definitely will help. If patients have diabetes, then I talk to them about the need for controlling their blood glucose level or their sugars, because having more control of the sugars when you have diabetes will definitely help with that, because diabetics can get an increased rate of cataract formation.
Do cataracts tend to be hereditary, run in families, or is that just not the case?
Actually, yes, it is a genetic component to cataract formation in some individuals. And there's a lot of studies going on about trying to understand the proteins that are in the lens and where are these proteins linked on a patient's genetics, to try to figure out what exactly makes a genetic component to one's cataract formation. But more commonly than a hereditary cataract is the age-related cataract. That is more common because everybody gets eventually an age-related cataract. Anybody who's aging develops a cataract. So it is interesting when one reads about the genetics involved of those patients who get a cataract not classified as age-related. Although it's interesting to try to figure out if it's coming from something hereditary or if it's coming from age, at the end of the day, a cataract is still a cataract in terms of the treatment approach. So it's more of just, say, a conversation, but at the end of it, we still treat them and remove them with the same approach, no matter if they're age-related or, say, genetically induced. There are also some infectious causes, some infections which some patients can get, or even get, like, say, in utero, and then born with issues that cause inflammations, which then lead to cataracts even at birth. These are not very common. They're just things that can happen, but they're not things we see very frequently as ophthalmologists.
I had a friend of mine that was being treated for an eye disorder and had to take some prescribed medication by the ophthalmologist and had to use it over a number of years. And it was a pretty harsh medication, and it kind of triggered cataracts. Would that be unusual that sometimes harsh prescriptions could trigger cataracts?
Well, so if you have an inflammation, what we call a uveitis, an inflammation in a part of the eye, these inflammations can happen from a variety of causes, from autoimmune issues to infections. Those are treated with steroid eye drops. And steroid eye drops, so therefore, can be used for inflammations. It's used also sometimes if there's, let's say a significant amount of dry eyes or another reason for inflammation. And steroids can be used for even bad allergic reactions in the eyes. But the overuse of steroid eye drops can definitely lead to cataracts forming, and actually a specific type of cataract, which we call posterior subcapsular cataract. We abbreviate it as a PSC, but a PSC, or posterior subcapsular cataract, can be induced from an inflammation in the eye that's treated with steroid eye drops. And that does increase the rate of cataract formation.
I'm going to pivot just a little bit. In a few minutes, I'm going to ask you about some of the treatment options, but it amazes me how far we've come in eye surgery. My uncle, many, many, many years ago, had cataract surgery, but when he came home, he actually had to have sandbags put around his head for like 2 to 3 weeks. I'm sure you're young. Have you ever read or heard about in what I would call past years, they had to use sandbags as part of cataract surgery?
And I'm not that young, but thank you. But I'm not that old that we were in my days of operating, we never had to use sandbags. But there have been a lot of changes since I've been operating, using our most modern techniques that are available to us. Our advancements have come so far that really a patient can resume their regular activity almost immediately. We do limit things like, say, lifting something heavy, because the wound that is made to take the cataract out is very small, that we don't even have to close it with a stitch. Because of that, we don't want somebody to lift something too heavy before that wound closes and heals on its own. But otherwise, the eye looks like a normal eye. It's not even red anymore. And patients can go about their normal, regular activities almost immediately. So unlike the olden days, let's say, when your life was turned upside down with eye surgery, now it's really just having like a procedure instead of such an invasive surgery.
And when we come back, you're going to hear about the results that surgery provides, and it is phenomenal. Dr. Karen Saland, ophthalmologist at Texas Health Presbyterian Hospital, Dallas, telling us about the latest in cataract surgery next when we come back.
Covering the healthcare topics that matter most to North Texas. This is the human side of healthcare with DFW Hospital Council CEO Stephen Love, along with Thomas Miller.
Welcome back to the human side of healthcare. Dr. Karen Saland, who is an ophthalmologist at Texas Health Presbyterian Hospital in Dallas, is talking about cataracts and the latest procedures to correct them. And there are some new technologies that she's going to tell us about next. So, Dr. Saland, what is new in cataract surgery?
So we all use phacoemulsification, which I have described to patients as like an ultrasound emulsification of the lens. The lens is the cataract. And we emulsify it and then sort of just, suck it out of the eye with that piece of equipment. There are some modifications that we use, but in general, we most of us use the same technique of phacoemulsification. The newer technology that has only come around in the last few years that's really revolutionized cataract surgery is the use of equipment such as an aura. It actually stands for Optawave Refractive Analysis, and that's been a huge change in cataract surgery. The phacoemulsification is something that we've been doing now for a long time, and almost every surgeon utilizes that technique. The new technology added, and the reason why I say it's sort of revolutionized cataract surgery is because we have to do measurements before we do surgery. We do measurements to help us determine what lens to put in somebody's eye. When you take out the cataract, you're taking out their natural lens. So we must put something in its place. And we call that a posterior chamber intraocular lens, PCIOL. We use a lot of abbreviations in ophthalmology. Everything's abbreviated. The artificial lens we put in its place is something that everybody gets one of these artificial lenses. So the new technology, what makes it amazing, is at the time of surgery, and you can only use that piece of equipment after the natural lens is out of the eye, before you put the new artificial lens in the eye, you can use this machine to do measurements. And the measurements are really precise way of predicting what the patient needs. It's like a customizable approach to choosing the lens. And it really, really makes it so that you can narrow down your lens selection so well that you can get patients out of glasses almost completely with the use of this technology, and in conjunction with having these like newer updated premium lenses, which we also have available to us. It's so different from when I came out of training even, and that it's very exciting. And these are lenses which are constantly improving, and they seem like they can't get any more amazing. And then someone comes up with a bigger and better lens that we can try. But right now, I would say that the best part of my job is seeing how happy patients are after their cataract surgery. They're happy with those standard lenses, but they're ecstatic with these other lenses. It's like vision, which many people have never had, meaning like if you've worn glasses your whole life and then you turn 40 and you can't read, so you're wearing then glasses for everything. You put these lenses in the eye after cataract surgery, these people then walk around with no need for glasses for anything. You can remove their need for distance glasses, for reading glasses, and you get rid of the astigmatism while you're at it. It's amazing.
It's truly a life-changing event, isn't it?
It is. And I try to tell people, because no one looks forward to having their eye messed with. And I hear people tell me every single day, I'm so afraid of having somebody touch my eye. And they're so worried when they're getting surgery that they won't be able to take it. Like it'll be just so uncomfortable or so scary that they won't be able to say undergo that surgery, and they'll have to stop. But in actuality, like during surgery, we make people very comfortable, even though they're awake, but they're so comfortable they don't feel anything. You can't actually see anything that the surgeon is doing. And almost everybody afterwards says, that wasn't so bad. When are we doing the other eye?
That's terrific. I do want to ask you this, though, because it goes back to patient responsibility. As remarkable as it is with eye surgery, once the cataract surgery is completed, the patient does have responsibility to put in eye drops you prescribe as you prescribe them, where they do them more frequently and then they're weaned off. Why is that so important?
So there's sort of two answers to that question. One, I will tell you, is that not every surgeon even uses the eye drops now, because there are ways of avoiding that by putting some medicine inside the eye at the time of surgery, and sometimes even a little small device that will release, say, medication into the eye. I'm still using eye drops right now. It's just, I guess I still just like the way I've always had my patients do it. And so I haven't changed yet to an additional injection inside the eye. But the reason why it's so important to use these drops, there are 3 drops that patients take. One is an antibiotic, one is a steroid, and one is a non-steroidal anti-inflammatory. So 3 drops, but really serving 2 purposes. Purpose 1 is we want to prevent infection. The rate of getting an eye infection that's, say, a debilitating eye infection, it's very, very low. It's a very small chance of developing a really bad eye infection. But clearly, no matter how low that chance is, we don't want it to happen to any of our patients. So we must then have patients use antibiotics. Not only do they use antibiotic eye drops, but the surgery staff takes the cleaning of the eye before surgery very, very seriously. It's not just a quick rinse of the eye. It takes them almost as long to clean the eye as it does for me to do my surgery. And that's how seriously they take it, because we want that rate of infection to be so low that we don't see it, right? Can't say 0, but at least that we won't be the surgeon that it happens to. And so we take it very seriously. So using antibiotic eye drops pre-surgery and then continuing it for about after surgery is just sort of keeping an eye on things and just trying to be on the safe side. Now, that being said, if someone does develop the early signs of an infection, fortunately, we take action very quickly, and there are treatments for it. That's the good thing. It just requires a patient saying, hey, you know what, my eye just doesn't feel right. We could quickly see the patient and do what we need to do. The second 2 eye drops, which serve the same purpose, is reducing inflammation. And of course, we've put in this ultrasound handpiece into the eye, and depending on the stage of the cataract, the more advanced that cataract is, the more inflammation usually develops in that eye at the time as we're doing the surgery. So therefore, it's important to use eye drops to reduce inflammation, which again, these eye drops, which we've kind of standardized, how long do we need to use an eye drop for to reduce and eliminate that inflammation that happens to any patient after surgery. And the good thing is we see people and we see them on post-ops. And if for some reason somebody has a little bit more inflammation, we can always just extend the use of the eye drop. And the non-steroidal anti-inflammatory is an additional once-a-day drop that just sort of has no side effects really, and just makes sure that the eye is healing as quickly as possible.
Thank you very much. I'm going to stop just a minute to see if Thomas has questions he would like to ask.
I have one very important question, Steve.
Okay.
Dr. Saland, do you have any appointments available on Thursday afternoon?
That is an excellent question. I couldn't have had a better question come out of your mouth at the end of an interview.
Oh, that's amazing. So let me ask you this. You're talking about a cataract lens, but you're saying it will fix vision too?
The lens will make your vision better probably than it's ever been in your whole life, unless you've been a person that never wore glasses pre-40. But if you're a person that had to wear glasses even as a young person, then you reach 40 where you have that additional presbyopia, inability to read up close. The lenses are amazing. These new lenses, we call them like premium lenses, multifocals, and they are outstanding. Now that we have this, you have people that come in, let's say in their 50s and 60s, which is young for cataract surgery. There are people in their 50s and 60s who can still see, but they have to wear glasses. So they want to have cataract surgery so they can get these multifocal implants.
And if you would like to learn more about the procedure and the lens, contact Dr. Karen Saland at Texas Health Presbyterian Hospital, Dallas to find out more. Happy Independence Day this weekend. We'll see you next week on The Human Side of Healthcare.